Load 253. With your exam coming up on Monday, I want to do a quick touch base about Unit 1. We covered a lot of material in the last few weeks, so I wanted to kind of hone in and focus down on all the different things, right? So we talked about the fact that mental illness is everywhere, right? Robin Williams. We see it all the time in movies, right? One Flew Over the Cuckoo's Nest, Nurse Ratched. They're kind of everywhere. Mental health versus mental illness, right? At the basis, mental health is well-being. We're doing good, right? We know our own potential. We can cope with stressors of life. When things happen, when you get a flat tire, you're able to handle it. We can work productive and we can contribute to the community. Mental illness includes our psychiatric disorders and a significant dysfunction. Right? The ability to think may be impaired, like in Alzheimer's, emotions, depression, behavioral changes, like in schizophrenia. 1 in 5 American adults have experienced a mental health issue, and 1 in 10 young people will experience just major depression. 1 in 25 Americans have a serious mental illness like schizophrenia. Suicide is the 10th leading cause of death in the United States. Right? Everything in this class will be on a continuum. You have, at the one side, mentally healthy, right? Everything's going great. You're doing well. You're high functioning, right? And then you can start to struggle, and we get into that moderately, right? We're not doing good or bad, right? I love the term languishing. We're not doing good. Our well-being is affected. We're low functioning. And then at the end, we get into mental illness. And that's where we have that DSM diagnosis and we have low to no functioning. So in mental health, we have a biologic and genetic factors, right? Nature versus nurture. There is a nature component to all of these. Resilience, the ability for people to cope. You can use the resources around you for well-being. It doesn't mean that stress doesn't affect you. It just means that you can cope with it. Social and economic circumstances, family, peer group, school, all of that, right? If we're doing well, they promote confidence and coping skills. But in others, it can promote inadequacy and cause anxiety. And all cultures have different views on mental illness. Traditional Japanese culture may consider suicide to be an act of suicide, and Middle Eastern suicide bombers are considered holy martyrs. So it's going to vary. The diathesis stress model says that some individuals have a predisposition, right? That genetic. You have a genetic predisposition to stress. And when a trigger is applied, when stress is applied, you present with a mental illness. And it can vary among people, and it can vary among cultures, and honestly, even with what the stress is. There could be some stress that you can cope with and other stress that's so much harder for you to cope with. 1990 was considered the decade of the brain. We're doing neuroscience. There's doing research. We're looking at like genetic bases and mapping genes. In 1999, the Surgeon General had a report on mental health. And basically the whole point of that, and it took till 1999, was to say that mental health is fundamental to overall health. Right? Human genome, we mapped the human genome. The Institute of Medicine report highlighted treatments for mental illness and a gap between best and worst care. And they looked at problems like forced treatments, lack of quality control. Legislation and mental health funding, the Mental Health Parity Act of 1996 basically said that insurance companies had to provide equal treatment coverage for psychiatric disorders. I was actually just reading an article today that basically says mental health parity and this whole act is a joke. And honestly, it's true because some individuals are still struggling because you have insurance companies who are like, no, why is this person needs to be in healthcare? And doctors are like, this is why they're going to kill themselves when they leave. And insurance are the ones choosing discharge dates because insurance companies don't want to pay for it. The Affordable Care Act provided more coverage for more uninsured Americans through Medicaid eligibility. It created health insurance exchanges. There was better prescription coverage, more preventative care, young adults could remain on parents' insurance, but some of these things weren't always adopted by some states. So it's a step in the right direction, but you still have many Americans not covered by health insurance. So the DSM is our checklist, and it covers every psychiatric disorder, and it basically says, right, here's our example from class. If you have borderline personality disorder, you have to have 5 or more of the following criteria. So of these 9 things, you have to check 5 boxes. And when you check 5 of the boxes, you have borderline personality disorder. And it's not saying that if you don't, let's say you only check 4, we still might diagnose you with traits of, especially if it's affecting your life. So there's 2 levels of psychiatric nursing, right? Your basic is your RN, right? So RNs can work in any general or specialty area. However, some RNs, like me, choose to work in psych. And you can actually go be board certified. They put PMHRN, but right now it's written as PMHBC. You could be anyway, you can go take an extra test and be board certified as a psychiatric RN. Advanced practice are RNs with an MSN or a doctorate degree in psychiatric nursing, and they're able to prescribe medications and make that medical diagnosis. So in nursing, well, I'm going to say risk of suicide. APRN would say the patient has major depressive disorder because an APRN is trained to give the diagnosis. And then they would be like, let's start Paxil, right? One of our SSRIs. So future challenges, it's hard for students, right? You have less inpatient facilities. A lot are closing. The cost is just not there. Individuals are getting older, right? We're seeing more Alzheimer's care. Cultural diversity makes it hard because we need to know about all the cultures of the patients we're dealing with, or at least have a willingness to learn. Technology, right? We have access to see the brain, MRIs, PET scans. Electronic healthcare has increased access for options to mental illness. A lot of patients are doing virtual visits. Patient advocacy is always important. As nurses, right, we uphold confidentiality. We always have to advocate for our patients. And legislative involvement. I can probably sit here and rattle off quite a few bills that are pending. There's one in the state, not the state, the Senate. Nope, House of Representatives. The House of Representatives, so I don't know. There's one in somewhere that's pending right now that would increase access to addiction treatment because right now Medicaid will not pay for addiction. So we need to see what's going on through policy and how it affects psychiatric and mental health nursing. And honestly, there's a lot that affects all of nursing. So the nursing process and standards of care. A lot of this stuff should not be new to you because these are things you've talked about in other classes. So quality and safety, right? 1990s, the Institute of Medicine came out with this report that said, hey, look, it's really dangerous to be in a hospital, right? We need to do better because patients are dying. And that is where, especially nursing students, right, a group of faculty adapted these competencies for nursing students in an initiative known as Quality and Safety Education in Nursing, QSEN. Right, that's on page 110, box 71 in your book. And basically QSEN, those competencies, says we need to focus on teamwork and collaboration, right? We have to have patient-centered care. We have to work in teams. We have to employ best practices. And y'all need to stay up to date on it as nursing students just as much as nurses need to. So the nursing process, right, we do an assessment still in psych. That's our mental status exam. We're going to ask about history. We're going to come up with a nursing diagnosis, risk for suicide, risk for harm to self or others, insomnia, risk for infection, risk for falls, outcome identification, right? If I have a patient with risk for suicide, my outcome, my patient will stay alive today. Planning, right? Evidence-based actions for what we're doing. And then implementation, we are going to take the steps. I am going to medicate my patient. I am going to make sure my behavioral health techs are rounding on my patient every 15 minutes. And at the end of my shift, I'm going to look and say, is my patient still alive? Age considerations, child. We have to look at feelings and emotions, and we have to look at the behaviors and conduct, especially of the parents. We have to look at the developmental level, And a lot of times what you see in kids is a regression. So they're going back to other stages. Adolescents are often concerned about confidentiality. And that gets hard because they don't always want their parents to know. So if an adolescent is talking to you and they're like, hey, I don't want you to tell my parents this, we often need to let them know that if these things are happening, right? If you talk to me about your feelings, I don't have to talk to your parents. But if you tell me that someone's hurting you, if there's abuse, or if you're threatening to hurt yourself, then I do need to tell someone, right? What is going to put the patient at risk? Older adults, we have to look at medical cause. Schizophrenia does not really start after age 35, 40, right? Schizophrenia comes on early. So if all of a sudden you have a patient who's 75 and hallucinating, they don't have schizophrenia, it's probably delirium. What is the medical cause, right? UTIs, is there a new medication? We have to look at their physical limitations. If they now have sensory or motor or medical problems, that can cause increased anxiety, stress, and physical discomfort. And we have to make accommodations for them, right? So in that assessment, the very first thing we do is we establish a rapport, right? We want to talk to our patients. We want them to trust us. We're going to review symptoms. We're still going to talk about medical concerns and medical conditions. And then we're going to do that mental status exam. It's box 114 on page 74. And we'll talk about this a little bit throughout the weeks in clinical, right? How does the patient look? Are they dirty? Have they not showered in a few days? Are they wearing super suggestive clothing and stripping naked in the day room? Right? How is their behavior? Are they able to sit appropriately in group and carry on conversations? Are they pacing the hallway? Are they talking fast or slow? Is everything they say rhyming? Right? Mood versus affect. Mood is subjective. Do they tell you they're happy or sad? Or are they angry? And objective, does their mood correlate to what their face is saying? Perceptual disturbances, right? Hallucinations and delusions. Thought disorders of kind of thought. Is their thinking disorganized? Do they know where they are? Do they have memory? Do they think it's, right? Sometimes you've seen Alzheimer's where they don't know what today is and they think it's 1980. Most importantly, ideas of harming self or others. We always have to assess for suicide and we always have to make sure our patients are staying safe. We watched that video where he went through it all. We have different rating scales. This is the PHQ-9. It's one of the ones we use more often. Spiritual and religious assessments, we have to look at it. It often gets overlooked, especially in psych. You see a whole lot of religious symbology, people who think they are reincarnated. Nursing diagnosis, right? We've kind of talked about these. This isn't any different than how you were going to do a medical, right? What is the unmet need? What is the patient at risk for? Looking at the bottom of Maslow's. Are they not eating? Are they not sleeping? Right? With mania. If someone has mania, we would do a sleep one. Related factors, what is causing it? Neurochemical or neurobiological imbalances are often easy, right? So defining characteristics, ineffective coping, related to alcohol abuse, as evidenced by patients stating, I drink when I'm stressed and depressed, it helps take the edge off. Outcomes, what do we want to happen? We want the patient, if we're doing ineffective coping, a short-term goal would be the patient will try 2 new coping skills today. Nothing unrealistic. And we're going to make sure our care is up to date. That we're not doing, there's a bunch of old school stuff people still do. So documentation, right? Narrative charting. What happened? Descriptive statements of the patient, right? Supportive statements. A lot of psych is charting by exception. So we want to talk about the significant symptoms, the behaviors, the events, right? That we can say subjectively, patient reports anxiety, 8 out of 10. Patient states that the world is ending in 3 days because God told her that. We can't say, we observe the patient looking anxious. We have to say the patient is pacing the hallway, wringing their hands and tearful. SOAP note, right? Subjective, objective assessment. We don't talk too much about it, right? We have to chart the time. We don't chart our opinion or false documentation. Big things to think about, right? If we're going to document patient refusing meds, we're just going to say the patient refused meds, we notified the provider. We're not going to go into specifics about it, right? We want to keep it short and sweet. We want to cover what happened. And unless like the patient punched you, we don't need to add more detail to it. So in day 2, we talked about that therapeutic relationship. The nurse-patient relationship, right? It's patient-centered, filled with dignity and respect. We're going to share information. And that relationship is the basis for all of psychiatric mental health nursing, right? And we talked about clinical. In clinical, we're not going to be doing things. We're going to be doing stuff with the patient. We're going to be having conversations, providing support, teaching a coping skill, right? Since many of the mental illnesses include poor self-image and low self-esteem, there's a lot of isolation. Even in schizophrenia, studies are showing that though it's often overlooked, they need some type of talk therapy because they need to form those relationships, right? The therapeutic use of self. Everyone is different, and you need to use your unique personality to form that relationship with the patient. So what do we talk about in the goals of the nurse-patient relationship? We want the patient to talk to us about the bad thoughts. We want to assist the patient in problem solving. We never tell the patient what to do, but we assist them in coming to a conclusion, to solving their own problem by helping them and providing them with information about coping skills. We want to help the patient examine self-defeating behavior. We want them to take care of themselves. We want them to be independent. Education is huge because we need to talk about medication and symptom management. And we want to promote recovery, and we want to focus on what is recovery for the patient. So a social relationship, that's what we have with our friends. We give advice, we lend money, the roles change, right? We don't ever really think about, did what I say was good or bad? We just say stuff. The therapeutic relationship is on the patient, and it's on their experiences. And we have to consistently focus on the patient, and we develop clear boundaries, because when those boundaries are blurred, that's when it gets iffy. We help the patient with new coping skills, right? Teaching. We support changes in their behavior for the positive, and there are clearly defined roles in a therapeutic relationship that don't change. So boundaries protect the patient. And you often see blurred boundaries, right? An under-involved nurse. They're going to sit at the nurse's station, and trust me, y'all will see this nurse at clinical. She's at the nurse's station. I have never, actually, I should take that back. I've once seen her like stand up and everyone was like, where did she go? Right? Or an over-involved nurse. I'm the one who understands this patient. No one else can take care of this patient as well as I can. And that, especially with that over-involved nurse, goes to counter-transference, right? The nurse is transferring feelings and behaviors onto a patient that signifies someone maybe from their past, right? I understand what the client is going through. No one else knows what the client is going to. Does the patient remind the nurse of their child or of their significant other? Or is their situation similar? Right? When I got divorced, this is what happens, and this patient is struggling with the divorce. It was just like mine, so I understand it. Transference is the opposite of countertransference. Countertransference, nurse to patient. Transferent, the patient is putting feelings onto the nurse. So the nurse reminds the patient of their mom. The nurse reminds the patient of their ex-wife. You also see those blurred boundaries where we're talking about the nurse's needs are met at the expense of the patient's, or we have a social relationship. You should never have a social relationship with a psych patient, ever. So self-awareness is a huge thing in forming that therapeutic relationship because we need to know where we each are. How are we going to write that therapeutic use of self? If you're uncomfortable with the patient, how are you going to go approach them? And our values and beliefs play a role in that. And they stem from our culture and the choices that we've made. Hildegard Peplau writes, fangirl, I love Hildegard Peplau. The nurse-patient relationship facilitates forward movement. We want the patient to make progress, and we want to talk about what we're not going to do to the patient, but what we can do to help the patient. And she developed the 4 stages of the patient relationship. So the pre-orientation phase, that's when you get a phone call that says, hey, you have this 35-year-old male with acute psychosis being admitted. And you get the history of the patient, or at least what you can get from report. The orientation phase is when you establish rapport. Hi, my name's Julie, and I'm going to be your nurse today. What do you like to go by? Well, on this unit, welcome to this unit. Here's your room. Here's the bathroom. This is when dinner is. This is when lunch is. If you tell me something in confidence, I will keep it as long as no one's getting hurt. And we set the bounds and the parameters of what the relationship will be in the orientation phase. In the working phase, we work to maintain that relationships. We're going to promote symptom management. We're going to gather further data. And then we're going to teach. We're going to talk about problem-solving skills. We're going to look at the language of the patient. We're going to look at their self-esteem. In the termination phase, we kind of summarize everything up. We say, hey, you did all this wonderful stuff while you're here. You're doing better. You've started on these meds. Your anxiety has gone from an 8 to a 10, from an 8 to like a 2. And you're going home. An important thing is there's an increase in suicide among discharge from psychiatric facilities. So we have to make sure that we're letting patients know where to follow up. Hey, you're leaving, and leaving can be hard and scary. If something happens and you start to have those unsafe thoughts again, you can call 988. You can call 911. Or you can go to the nearest emergency room, or honestly, just drive back here and come back here. We have to make sure the patient understands that safety of a discharge plan. We talked about good nurses, we talked about good coworkers, genuineness, empathy, and positive regard. We need to get our patients to grow, and we can do that by showing genuineness and empathy. Show them that we truly do care about them. Therapeutic communication, we went over this in clinical. Those of you who have clinical coming up for the first time, you will see this again. So we have a whole process, right? We need to communicate something. Someone's the sender. There is words coming out. Is it auditory, visual, olfactory? The receiver, who are we talking to? And then feedback, right? So feedback's like me sitting in class and I can see y'all falling asleep, or I can see y'all nodding, agreeing with me. So what affects communication, right? Personal factors are huge. Is cognitive function. Does someone process information slowly? We might need to use silence. Anxiety. Someone who is having a panic attack cannot carry on a conversation. Language barriers. Using professional interpreters. We should not be having family members or someone else interpreting. We should call the language line, get the language computer, whatever it is. And education. Right? If we're telling everyone like, yes, you had emesis today. They don't know what emesis is. Environmental factors are huge, right? Lack of privacy, noise, it's uncomfortable. We want to form a comfortable environment, right? We want to be sitting. We don't necessarily want to be like behind them or, right across from them, maybe 90 to 120 degrees, a little angle. Make sure there's nothing between us and them. The door is always an iffy one because we don't always want to put the patient, we don't always want to put the patient, I don't know, it's weird. We just got to watch. There's a good table in your book and section in your book that talks about it, of how we set it up. Verbal, everything we say. Nonverbal, our tone, not what you said, but how you said it, right? Our facial expressions, our body language. This makes up more, right? Nonverbal makes up more of our communication than verbal. So therapeutic communication. There are some awesome therapeutic communication techniques, right? Hey, let's talk about this. Hey, we talked about this today, right? Restating is always a good one, right? Summarizing. Reflecting back, helping the patient to explain their own feelings. The tables in your book are really good for looking at these, right? Table 9.2. They're wonderful things that you can do. And honestly, sometimes it's easier to know what's non-therapeutic because there's a little bit less of that, right? So we want to make sure we're not doing these things. I know what you mean. Everyone feels that way, right? Falsely reassuring. Everything will be okay. Asking why questions. If you see a why, it's always wrong. Asking excessive questions. Excessive questions just cause a patient to shut down, right? Giving approval or disapproval. That's really good decision. It doesn't matter if we think it's a good decision. Disapproving, right? You really should have done this, or you really should have done this, or I disagree with your decision. And changing the subject. Those are sometimes the easiest ones to kind of remember. And we did a bunch of those questions, right? More therapeutic communication. We want to focus on open-ended questions, kind of like the what if. Closed-ended questions are okay sometimes. They're best in emergency type situations, or if we really just need to get this information like during an assessment. But therapeutic communication, it's going to be anything that's encouraging the client to talk. So cultural considerations, right? French, Italian Americans have more animated facial expressions, hand gestures. Some cultures find eye contact to be disrespectful. Therapeutic touch is good in some ways, but also bad in others. We never, ever, ever want to touch in a psych unit. But if we're sitting with our little old Alzheimer's patient in a long-term care or memory care unit, right, putting a hand on their arm, if they're okay with that, can convey respect and empathy and help connect you to the patient. So the clinical interview, the patient sets the pace. We want to have a feeling of security in a quiet area, relative privacy, right? Assume the same height, avoid a face-to-face arrangement, safety and comfort. So you don't want to position the patient between you and the door, but you also don't want to make the patient feel trapped in the room. We want to provide introductions, where should we start? Tell me a little bit more about yourself. And keep it simple, let the patient go with the flow. So there's a sample of the process recording in your book. I've posted a sample. It's in your clinical packet. Some of you have already done one, and the rest of you will do it in just a day. So that is Unit 1, right? We've done all those practice questions. Y'all had them handed out. We went over them in class. If you have any questions about Unit 1 before, honestly, next Monday, reach out and let me know.